Please allow me to introduce Prof. Ronald Summers, a senior investigator and staff radiologist at the NIH. Ronald Summers received the BA degree in physics and the MD and the PhD degree in medical anatomy and cell biology from the University of Pennsylvania. His research interests include deep learning, virtual colonoscopy, CAD, and the development of large radiologist image databases. His clinical areas of specialty are aortic and abdominal radiology and body cross-sectional imaging. He is a member of the editorial board of the Journal of Medical Imaging and Academic Radiology and a past member of the editorial board of radiology. He is a program committee member of the computer-aided diagnosis section of the annual SPIE Medical Imaging Conference and will be co-chair of the entire conference in 2018 and 2019. He was program co-chair of the 2018 IEEE ISBI Symposium. His speech title is Challenges and Opportunities for AI in Abdominal Radiology. Ronald Summers.
Thank you very much for that introduction. Can you hear me okay and see my slides?
Yes, I can.
Great, thanks. Thanks everybody for being here on a Sunday. I really appreciate it. It's a great pleasure to be here to talk with you today about the research I've been doing in AI and abdominal radiology. These are my disclosures. And much of the research that I'm going to show to you today was done at the NIH Clinical Center in Bethesda, Maryland, located just outside of Washington, D.C. Our hospital is the largest hospital in the world devoted entirely to clinical research. So many of you may be unfamiliar with some of the subspecialties of radiology. I'm an abdominal radiologist. Abdominal radiology is a clinically highly important subspecialty of radiology with its own professional society, the Society of Abdominal Radiology. And there are numerous important abdominal organs and lesion types. And these include things like liver and liver disease, kidney and kidney disease, and so forth. Now, what makes abdominal radiology so exciting from the AI perspective is that it's a relatively less studied area, and that means that there are a lot more opportunities for new developments. This histogram shows the number of papers published in radiology and machine learning over the years, and you can see an exponential growth in the number of papers being published here. But if you look at the blue bars, you'll see that in abdominal radiology, there are only a small number of publications. Again, getting back to my point that there's a lot of opportunity in this area. My group has worked on abdominal radiology AI for many years. We've developed a number of AI systems for things like precancerous colonic polyps, identifying the bones in the spine, measuring osteoporosis in the elderly, which is a particularly important issue for women in particular, identifying cancer spread to the spine, such as this cancerous deposit here, small bowel imaging. Small bowel is shown in this blue coronal image. These are major organ segmentations, such as liver, spleen, kidneys, aorta, and adrenal glands. This is a kidney with multiple tumors, and this is an abnormal lymph node in the abdomen in a cancer patient. So there are many different possibilities for machine learning and radiology. So in the next part of this presentation, I'm going to talk about an area that we've been focusing very closely on over the last few years, and that's body composition analysis. When you go to the doctor, frequently the doctor or his or her assistant will measure your weight and may measure other body composition parameters such as your waist circumference, your body mass index, or your lean muscle mass. And the reason that they do that is that these are surrogate biomarkers for health and risk of disease. So, for example, if somebody has an anticipated weight loss, this could be a worrisome sign of something going on that needs to be worked up by the physician. And these body composition metrics are playing an expanding role in clinical research and practice. So I've been working on a large-scale body composition analysis project with my colleague Perry Pickhardt at the University of Wisconsin-Madison. He's shown here. This project's now in year 12 and has led to 30 clinical papers using AI systems that combine both traditional image processing and deep learning. At the moment, we have 5 tools that have been well validated, and I'll talk about some of our most recent tools at the end of this talk. And these tools have been continuously improved as developments in deep learning provide new methodology. So the 5 body composition tools that we developed are shown here. These include measuring the calcified atherosclerotic plaque in the abdominal aorta here. This is the liver on a CT scan, and we measure whether there's any fat in the liver. This tool in the lower left is a muscle tool that identifies all the muscles in the body wall. This one measures bone mineral density to assess for osteoporosis, as I mentioned earlier. And this one here identifies the fat. There's 2 types of fat: subcutaneous fat, which is just under the skin, and visceral fat, which is inside the abdomen itself. So for each of these tools, after we develop them, we validate them. This is an example of the bone mineral densitometry tool, showing how bone mineral density decreases as we get older. And the tool identifies the L1 vertebral body, shown here on a sagittal CT image, and then makes a measurement of the density in the bone. The second body composition tool is the one that measures the fat. On the left, you see images of the same person who was scanned in 2007 and in 2017. This person had a lot more visceral fat in 2007. That's the blue labeled structure than in 2017. And one of the things we found in this study was that men tended to develop visceral fat at a greater rate than women did, and women tend to develop subcutaneous fat at a greater rate than men did over the lifespan. And the reason this is important is because there's a thought that the visceral fat may be metabolically active and can be associated with different diseases like diabetes and decreased survival and other morbidity. This particular machine learning method used traditional image processing techniques, including anisotropic diffusion, fuzzy C-means, and active contour models. And in a validation study, we showed that using these Bland-Altman plots, that the accuracy of this technique was highly accurate, with roughly a plus or minus 2% difference in different measurements. The third tool that we've been using for body composition analysis is abdominal aortic plaque calcification. The tool identifies the abdominal aorta, which is this round structure here just in front of the spine. And then there's a preliminary plaque detection. Sometimes this will get some of the calcium in the bone, which is not what we want. We get rid of that, and then we have the plaque in the abdominal aorta. And what we found is that with aging, the amount of plaque increases with a dramatic increase between the 60s and 70s age ranges using different metrics, including the Agatston and volume and mass scores. And here you can see men shown in blue. They have larger amounts of plaque than women shown with the red bars here. Our plaque assessment tool has been continuously improved. Initially, we used a 2D mask RCNN that would first identify the true plaque class and then compute features using the convolutional neural network. And then we would, unfortunately, the technique in its initial implementation also identified other calcifications like in bone. So we used pseudo-class labels by clustering CNN features, which then was able we could then retrain a CNN model using a true class and pseudo class technique. And that led to rejection of some of these false positives on bone and calcifications that weren't in the aorta, so that we could just see the calcifications in the aorta as shown in these two examples. So that first technique, as I mentioned, was a 2D mask RCNN with a ResNet 50. It was trained on low-dose non-contrast CT scans and had 85% sensitivity at 10 false positive plaques per patient, which was a pretty good performance, but we moved to a 3D model shown in this example that could also detect plaques on both non-contrast and contrast-enhanced CT scans. So in the lower left, we have non-contrast CT scans. The lower right, we have contrast-enhanced CT scans. These are the same patient. And the plaques are shown here on these sagittal CT images. Here's the detection of the plaque on both the non-contrast and the contrast-enhanced scan. And here's another example on a contrast-enhanced scan showing somebody with a lot of plaque, and that's accurately detected by the technique. This improvement used a modified 3D UNet with a dice loss. It was also trained on non-contrast CT scans, but also additionally 23 CT urography scans to distinguish a common false positive on contrast-filled ureters. And then we tested it on over 900 CT colonography scans and 1,207 paired scans from renal donors. And it had high correlation and agreement with manual methods. And the key thing was that this could work both on the non-contrast and the contrast-enhanced scans. So now I'll talk about the fourth tool, and this is the skeletal muscle tool that identifies all the muscle in the abdomen, and this is done at the L3 vertebral level. The muscles are these gray structures on the CT scan here, and here they are highlighted in red by an automated technique. These are two different patients. The patient on the top has a normal distribution and type of muscle, and the person at the bottom has much less muscle and has fat. That's the dark pixels that are in the muscle bundles here. So this person has both less muscle and poor quality muscle, and that has implications in making this person more frail and likely to either develop fractures, fall, and also have complications like heart attack and stroke. I'll show you a little bit more about that later. This particular AI tool for skeletal muscle, again, we analyzed it across the lifespan. You can see muscle density tends to go down with increasing age. Muscle area also decreases, although not as rapidly as muscle density. And men tend to have higher amounts of muscle than women, and also their muscles tend to have less fat in them than those of women. The initial version of this tool was a 2D UNet that was trained on 102 training and testing cases and was on contrast-enhanced CT. Initially, we thought that it was important to look at different muscle groups independently. So, for example, these are dice coefficients of the automated technique for different muscle groups. This top group here is the paraspinous muscles. That's these here. This middle group is the psoas muscle, which is this muscle here. And the bottom group is all the muscles, everything in red in this picture on the right. And you can see that for the total muscle group, there's less variability. In these box and whisker plots, the size of the box is much smaller. And that's why we decided rather than looking at individual muscle groups, we look at all the muscles since we get the highest dice coefficients. The fifth and final tool is one that segments the liver and measures its average density or attenuation. And in typical clinical practice, radiologists measure the size of the liver by measuring the linear height of the liver from the top to the bottom on a coronal image. And this isn't the best choice because livers have very different shapes, and sometimes where you measure makes a big difference. For example, all I have to do is measure a couple centimeters over here and you'll get a much different height. However, if you measure the volume, that's something that, if it's reproducible, would be very consistent from one measurement to the next. This example shows an assessment of the liver of a patient who, over the course of 10 years, developed fatty infiltration. You'll notice that their liver, which is this structure here, gets darker and darker, and at 10 years, it's much darker than it was on the initial CT. This liver is filled with fat, and fat in the liver is a risk factor for cirrhosis or fibrosis of the liver, and that can lead to poor liver function. In this validation study we published in Radiology in 2019, we found an excellent correlation between manual and automated measurements, 0.92. And in this confusion matrix, we found excellent classification of different amounts of liver fat, comparing automated and manual measurements. Now, one of the things we've been interested in my group is applying these techniques to scans obtained in different ways, for example, with and without intravenous contrast. And one of the ways we've done that is use generative adversarial networks to convert true contrast-enhanced CTs to synthetic non-contrast CTs. And in this particular application, we use that this method to develop a liver segmenter that worked on both contrast-enhanced and non-contrast CTs. This method used a 3D UNet with a cycle GAN to convert the contrast to the non-contrast CTs, and we used over 200 scans from the liver data decathlon to train the system. And we found that this cycle GAN method led to high Dice coefficients for the liver on the out-of-distribution non-contrast CTs. So now that we had developed these 5 different AI tools, we wanted to figure out whether they could shed some light on cardiovascular risk and overall survival. So what we did was we collected 9,000 CT scans of men and women undergoing colorectal cancer screening with CT colonography. We ran the 5 different AI tools that I just mentioned, and we predicted overall survival using these different AI outputs, either singly or in combination. And what we found was that compared to traditional clinical methods of assessing risk for early mortality, such as the Framingham Risk Score and Body Mass Index, these AI tools in a multivariate analysis had a very high area under the curve for predicting overall survival of 0.811, which exceeded that, for example, of Framingham Risk Score, which is a very popular method that doctors use. This is an example of an asymptomatic 57-year-old man whose scan was analyzed using these different tools. You can see he had a lot of visceral fat shown in blue on the left. He had low liver density here. He had a lot of plaque in his abdominal aorta. And 12 years after the original study, each of these progressed. He had even more fat in the liver, shown here. He had even more plaque in the aorta and had even more fat in his visceral component. This particular man developed a heart attack 3 years after the initial CT, and he died 12 years after the initial CT at the age of 64. Another project that we did was looking at whether the AI tools could predict major osteoporotic fractures. And this is an example of a 59-year-old asymptomatic woman who had a CT scan. The AI tool showed she had a very low bone mineral density. She had very low muscle density, indicating frailty. And she developed a hip fracture shown here on this X-ray 3 months later. And if we had gone back to earlier CT scans and made measurements of her bone mineral density, we would have found that over time, her bone mineral density was steadily decreasing, which shows a potential application for this AI suite of AI tools. Another project we looked at was longitudinal follow-up of calcific plaque. Here's an example of a patient with plaque at different time points. This is a later scan than this one. This is a segmentation of that plaque. And what we found was that patients who subsequently had some sort of adverse vascular disease outcome, like a heart attack or stroke, tended to have progressive increases in their abdominal aortic calcific plaque compared to those that didn't have one of these adverse outcomes. I'll now briefly talk about some other projects that we've worked on over the years. Perhaps some of these ideas that I'm sharing will inspire you to work using some of these similar methods. This was a project we called a key images project, where we had 780,000 radiology reports and 216,000 key or important images. And we were able to use both the text and the images to train a CNN to label images. So for example, this MR image during testing was labeled as having a kidney mass, which was correct. This is the kidney mass. This project is called the Deep Lesion Dataset. This is a dataset of over 32,000 lesions on CT scans that we've made publicly available. This dataset has been downloaded thousands of times and been cited in hundreds of publications. We've, in my own group, we've used this data set as to develop universal lesion detector that can find lesions in the neck, chest, and abdomen, as shown in these examples from a MICI meeting several years back. We've also publicly released a data set of patients, cancer patients with enlarged lymph nodes in the chest and abdomen. You can download that data set in the Cancer Imaging Archive. And we've more recently started working on T2-weighted MRI images and lymph node detection in these two examples of abnormal lymph nodes shown in these yellow and green boxes detected by an AI system presented by my colleague Tejas Mathai at a MICI workshop. Automated measurement of cancerous lesions is something that may prove useful in clinical practice. This is an automated lesion measuring system that uses machine learning techniques called spatial transformer and stacked hourglass networks to measure the size of cancerous deposits on CT scans. This is a comprehensive spine oncology image analysis tool that identifies different cancerous deposits in the bones in the spine. For example, punched out lesions such as this one called a lytic lesion, and bone forming cancers like this one that makes the bone appear white. Another data set that we've released is the pancreas CT data set. This is also in the Cancer Imaging Archive. This is an example of a pancreas in this data set. The data set also includes manual segmentations of the pancreas and has been used by a number of groups for developing techniques for identifying pancreatic cancer. I'll now briefly run through some other abdominal AI applications that we've worked on, again, hopefully to inspire you to think about some of these problems and how you might solve them better than us. This is a project led by Sungyeon Shin, who's currently a postdoctoral fellow in my group, and it's for small bowel image analysis. He has done a series of publications looking at different ways of segmenting and identifying lesions in the small intestine. This method used principles from topology to identify the small bowel, as shown in these 3D and 2D images. This technique disentangled intensity and non-intensity features with a two-stream auto-encoding architecture to identify the small bowel and reduce false positives. And this technique published in this year's MICI showed a method of tracking the lumen of the small bowel in order to develop a coordinate system to precisely localize lesions in the small bowel. This project looked at pancreatic CT and diabetes. This is the pancreas for a patient without and one with diabetes. And in this particular project led by Hima Talam, who's a medical student now in an MD PhD program, she was able to show that with increasing numbers of years of suffering from diabetes, the CT attenuation of the pancreas progressively decreases, as shown in these examples of patients with different numbers of years of history of diabetes. And in this final example, I'll show on cirrhosis or liver fibrosis. These are patients with small, irregular, shrunken livers, sometimes surrounded by fluid. In this method developed by Grace Sungwon Lee, former postdoc fellow in my group and now a physician in South Korea. She developed the method to identify the different segments in the liver shown in these different colors, and also the spleen shown in purple here. And you can see as the amount of fibrosis or cirrhosis increases in a liver, these red and orange parts of the liver get bigger and bigger, going from normal to abnormal on the right. And you can see that graphically in these violin plots that the size of the left lobe of the liver increases compared to the right. So there are still some challenges and questions being worked on, not just in abdominal radiology AI, but throughout medical imaging AI in general. These include questions of how to make these techniques interpretable and explainable, how to deal with brittleness due to domain shift, and how to reduce bias and strongly consider things like ethics and trustworthy AI. And I think things like the generative adversarial networks to develop synthetic images may be one way to help with the brittleness and domain shift problem, and perhaps with some of the bias-related problems. There are a number of lessons that we and others are learning from the COVID era. It's very important to avoid duplication of effort when developing these AI systems, and clinically relevant data and endpoints are key. And if you'd like to learn more about those topics, please take a look at my editorial in radiology. We've been looking at approaches to using less labels, for example, using zero shot, few shot, and transfer learning techniques, as well as some of these other techniques. I think this will be an exciting area, particularly for rare disease diagnosis in the abdomen. So to conclude, the abdomen is a relatively less studied area, but the gap is closing. There are many potential practical clinical benefits for AI in abdominal radiology. I'd like to acknowledge my colleagues and funding sources. I thank you for your attention, and I'd be happy to answer any questions.
Thank you. Thank you for Ronald for his excellent speech. If anybody have any questions, please feel free to ask. Maybe there are no questions. Oh, sorry. Wait a minute, there have questions. Wait.
No questions. It was completely obvious to everyone.
There have questions.
Hi, my name is Professor Rabani. I'm from Qatar University. I was wondering, you have shown excellent data, I mean, radiology and all the images, beautiful. I was wondering that how, I mean, all the conditions you mentioned, is it possible that you could predict these conditions before it happens? Or rather than at the later stages, can you detect all these using machine learning and images at very earlier stages?
Right. So can we predict some of these before they become clinically significant? When we looked at the patients with diabetes, what we found was that there were changes in the pancreas that preceded their diagnosis. And that's one potential application. Perhaps it might be possible to do that. I think similarly with the atherosclerotic plaque example that I showed, people start developing plaque before they develop morbidity. And that might be another potential way. But, you know, many of these techniques do seem to be predictive. For example, the osteoporotic fracture paper showed that the hazard ratios were elevated in patients that had certain adverse findings that were found by these AI tools. So, the quality of the prediction varies. Even with the hazard ratio of 2 or 3, you're still predicting many more potential adverse outcomes that actually occur, and whether we can improve the quality of that is unknown.
Right, okay. It's just I understand with the osteoarthritis images, MRI and X-rays don't really show anything until it is too late. And so it is a great tool, imaging, but something can be missed or predicted early, and by the time you know about it, it's too late. I have been looking at the biomarkers in the blood, and some of those biomarkers, specifically cirrhosis, liver cirrhosis, there are certain markers elevated very, very high, even at early stages, and same with osteoarthritis. Even the patient don't have a pain, severe pain, very first time they go and see the doctor, certain biomarkers increased in the blood. So I am currently correlating with MRI images or X-rays. So I was wondering, with all your cohort, all your patients' images, do you have blood samples maybe stored where we can look at that early stages if these markers can predict what you see in the images?
Right. Well, for example, the cirrhosis patients that I showed you have been under study for many years at my hospital, and that is one of the goals of their projects. So they have been doing genomic analyses, serum analysis for multiple biomarkers. That is a fairly extensive analysis of the patients with cirrhosis. The integration of the imaging with the serum biomarkers and genomic markers is, I think, only going to increase over time. We are doing some work in that area. I don't have anything to report to you at the moment, but I agree with you that those are promising directions.
Thank you.
Thank you.
Thank you. Thank you for your excellent questions. Any other questions? Maybe there are no questions now. Thanks again. Thanks for your excellent speech. Thanks, Dr. Ronald.